Hello.
Everybody has joined? Muthu Samit sir, I don't think sir has joined.
Kudush Ramesh sir has joined.
Author
Dr.
is there.
Rajyoti has joined.
Rajyoti is there.
Yes.
Yeah.
And the people will be joining time to time. I think we
Okay.
should
Yeah.
start, madam.
Okay. Good evening. Good evening, everyone.
Good evening,
So
madam.
welcome you everyone in the 11th NEBOI classroom. So we are going to start our program, and I request our President, Dr. Shobhamay Chakraborty, to introduce our expert, sir.
Thank you, madam. So, good evening, everyone. Welcome to this 11th webinar, NEBAOI classroom today. And we are all grateful to our external expert, Professor Dr. Nitin Madhusudan Nagarkar, sir. In spite of his busy schedule, he has given consent to become the external expert, sir. We, from the NEBOI family, we are grateful to you. So, Professor Dr. Nitin Madhusudan Nagarkar is a distinguished academician, surgeon, and healthcare administrator with over 3 decades of experience in medical education, clinical care, research, and institutional leadership. He is the former director of AIMS Raipur, where he served as a founder director from 2012 to 2023 and also held additional charge of AIMS Bhopal. He previously served as a Vice Chancellor, Medical and Health Sciences, SRM Institute of Science and Technology, and Dean Medical, SRM Medical College and Hospital and Research Center, Kattan, Kattankularthur campus in the district of Tamil Nadu. Dr. Nagarkar completed his MBBS degree with honors from esteemed Patna Medical College Hospital. He further honed his expertise by completing his MS in ENT from prestigious Postgraduate Institute of Medical Education and Research (PGI-MER) Chandigarh and obtained DNB in ENT from National Board of Examination New Delhi in 1992 and 93 respectively. He has more than 3 decades of expertise in his experience in his profession. Dr. Nagarkar is also recipient of Doctorate of Science honoris causa from Amity University in 2023. He is an expert in ENT head and neck surgery with a focus on oncosurgery and skull-base surgery. He has worked as a Dean Medical at SRM Medical College and Hospital from July 2023 up to January 2026. Dr. Nagarkar has authored more than 150 scholarly articles shedding light on various aspects in ENT and oncosurgery, both in national and international journals. He has authored 2 books, namely Rhinosporidiosis and Atlas of Head and Neck and Skull-Base Surgery, and also contributed 6 books chapters. He holds 4 patents and 1 copyright. He has contributed his academic professional expertise in more than 150 national international conferences as director, chairperson, and resource person. Dr. Nagarkar served as a member of the Academic Council of Indira Gandhi National Open University in New Delhi between December 2013 and December 2015. He was a valuable member of expert group of research at IIM Raipur as well as a member of Court of Guru Ghasidas Vishwavidyalaya. It is a central university in Bilaspur, Chhattisgarh, nominated by Ministry of Human Resource Development from January 2014 to 2017. He was a member of various committees constituted by Government of India for setting up new AIMS institutions in the country. He presently also serves as a chairperson of Evaluation Committee in the Healthcare Sector Skill Council. Dr. Nagarkar excelled in multiple subjects during his MBBS, earning distinctions. He also awarded prestigious medal at PGI Chandigarh for his outstanding performance in MS examination. Dr. Nagarkar has delivered 10 auditions across the country. Dr. Nagarkar has received numerous awards in his contribution of the healthcare. He got Distinguished Service Award by Delhi Medical Association in 2006, Times of India Icon of Health Award July 2016 and 2017. Dr. Nagarkar has been nominated by Government of India as an institute body member of JIPMER Pondicherry with effect from November 2025 onwards. Furthermore, his dedication to medical education is evident in his role as an examiner in various universities, where he has evaluated candidates pursuing MBBS, DLO, MS, and PhD degree, including DNB examiner. He previously served as a Pro Vice Chancellor, Medical and Health Sciences at SRM Universities at Chennai, SRM Medical College, top-ranked institution by NIRF and other reputed agencies. He was constantly providing leadership in the advancing medical education, patient care, research, innovation, community outreach in all streams of medical, dental, nursing, pharmacy, public health care, and allied health sciences. He is now assuming the role of Vice Chancellor, Apollo University, Chittoor, Andhra Pradesh, from July 2026 onwards. His continuing commitment to excellence, higher education, healthcare, research, innovations. Sir, thank you very much and welcome in NEBAOI Classroom 2026. Thank you very much, sir.
Thank
Thank
you,
you
Dr.
very
Shubham.
much. Thank you so much for the very kind.
Welcome, sir. Sir,
Thank you.
welcome to the program, sir.
Thank you, ma'am.
Dr. Anjan Bhaiya, are you there?
Oh, yes, I am here. But
Okay,
I
can
am
you
inside the car. Yeah. No, I can carry on.
Can you introduce
Yeah,
Dr. Dakar, Ardent Kit Kapoor Dakar?
yeah. Today, our speaker is Dr. Arden Kit Kupar Thakkar. Okay. So, he is presently a senior resident in Bibora Cancer Hospital. So, he passed out from his bachelor degree from Karnataka. His college was Sri Sridhara Medical College. And he did his postgraduate from the Christian Medical College, Hellore, from Tamil Nadu. He had a great experience of his as a practitioner, medical practitioner. He was working in Dr. H. Gordon Roberts Hospital in Shillong as an ENT consultant and as medical officer. So presently he is as a senior resident in Bibora Cancer Hospital. So I welcome Dr. Ardent for his speech. Thank
Dr.
you,
Ardent.
Dr. Pujaba.
Dr. Ardent?
Yes, thank you, sir. Yes, sir.
Yeah, you can start your program. Oh, acha,
Let me introduce our moderators.
Dr. Yeah, sorry, madam. Dr. Yeah. Hiranyavardhan Bora, madam, please introduce our moderators.
Actually,
Sir.
Today our moderators are Dr. Kudus Ahmed sir and Dr. Rupjyoti Das. So about Dr. Kudus Ahmed sir, we don't need any introduction. He's a very famous person, but still, he passed his MBBS from Dibrugarh, Assam Medical College, and MS degree from Safdarjung Hospital, New Delhi. And now he is a chief consultant, ENT head and neck onco surgery, Dispur Hospital and Nightingale Hospital, Guwahati. And formerly he was chief consultant, HOD, head and neck oncology, B. Borua Cancer Institute, Guwahati. And professional affiliation, founder member of FHNO, founder member of Association of Oncologists of Northeast India, life member of Association of Otolaryngologists of India, life member ISTS, life member NEBAOI, life member NEHONF, Northeast Head and Neck Oncology Forum, life member Association of Phonosurgeons of India, life member All India Rhinology Society, and life member of Indian Association of Palliative Care. About professional position, he was a member of Governing Council of FSNO, past president NEBAOI, past president all Association of Oncosurgeons of Northeast India, past president Northeast Head and Neck Oncology Forum, and past honorary secretary FSNO. Special interest in head and neck oncology, thyroid and parathyroid surgery, and salivary gland disease. His honors conferred to him Dr. Somnath Ghosh Memorial Oration. It is a long list. Dr. Pramod Deka Memorial Oration, Dr. Heramba Kumar Bharali Memorial Oration, Lifetime Achievement Award for outstanding contribution in the field of head and neck oncology by 22nd FHNO Annual Conference Guwahati, Presidential Oration, 12th Annual Meeting of Association of Oncosurgeons of Northeast India, Jorhat Academy Oration of NEBAOI, Satyavan Roy Memorial Oration of the North Bengal Chapter, Dr. R.N. Mehor Oration at the Annual Conference of AOI Vidarbha Chapter, Presidential Citation for Propagation of Head and Neck Oncology across the country, and Dr. S.N. Sharma Award Oration at NEBAOI Annual Conference, Shillong 2001. I welcome Quddus Ahmed sir for this session as moderator. Our second moderator is Dr. Rupjyoti Das.
Is Rajjyoti.
Oh, sorry. This is Rajjyoti. Moi Sodai Rupjyoti boli kau je. Rajjyoti Das, Professor of Head and Neck Surgery at BBCI, B. Borua Cancer Institute. More than 25 years of experience in head and neck surgery. A teacher for MCS Head and Neck Oncology, Head and Neck Surgery, a 3 years MCI recognized course. More than 45 publications in peer-reviewed national and international journals. He attended World Congress of Thyroid Cancer as faculty at Boston, USA. Attended 5th and 6th Congress of Asia Pacific Society of Thyroid Surgery as panelist and speaker at Thailand and Singapore. Invited as speaker and moderator to Annual Conference of Asian Society of Head and Neck Oncology at Vietnam. He is the author of 2 chapters in 2 textbooks. He completed many research projects under Department of Biotechnology, Government of India. He attended many national and international conferences as speaker, panelist, and moderator, and he is an active member of Asia Pacific Society of Thyroid Surgery, FHNO, ISTS, ISO, etc. I welcome Dr. Rajjyoti as moderator for today's session.
Thank you,
Welcome,
ma'am.
Dr. Rajjyoti and Quddus Da, Dr. Quddus Ahmed, sir.
Thank you.
Thank you,
for your
Hiranaveda.
introductions. Yeah, thank you.
Now, Dr. Arden, Arden, please, can you start your presentation, and your time is 30 minutes.
Yes, sir. Thank you, ma'am. Ma'am, is my screen visible, ma'am?
Yeah, visible. Full screen, do it full screen. Yeah, fine.
Okay. Good evening, respected teachers, colleagues, and friends. So my name is Dr. Arden Kit Kapodakar. I am currently a senior resident and a fellow studying in the Department of Head and Neck Oncology in the BBCI, Guwahati. And today I will be presenting on the topic early oral cancers, workup and management. So according to the Globocon data 2022, in India, head and neck cancer has the second highest incidence of 10.2%, and it is more commonly. So these are the learning objectives that I will be talking about today. So according to the AJCC 9th edition, oral cavity subsites has been divided as mucosal lip, anterior 2/3 of the tongue, the floor of mouth, the buccal mucosa, the upper and lower gingiva and alveolus, hard palate, and retromolar trigone area.
Arden,
And
is there
yes,
any other system is opening? Because there is some disturbance, little disturbance is there. Any other system is also there or what near you?
no, ma'am. No, ma'am. No, ma'am.
Some disturbance is there. Okay, carry on.
And AJCC has clearly classified early disease for stage 0 as carcinoma in situ, stage 1 as T1 N0 M0 diseases, and stage 2 as T2 N0 M0. So here is a photo taken from patients at our institute. The first photo is showing a T1 lesion in the lateral wall of the tongue, and the second photo is showing a T2 lesion in the right lower gingival buccal surface.
And where are you now? You are in OT or what? Arden, can you hear us?
Yes, sir, I can hear you.
Your voice is not clear. Audience are not able to understand clearly. Can you change the place a little bit if it's possible?
Uh,
Where are you now?
Very OT, sir.
You're in OT.
Yes.
Okay. Your voice is not that clear. I don't think that audience is able to hear it clearly. Okay, carry on, please.
Or there is, he can switch off his video also for the time being.
Continue, Arden, please.
Yes, continue.
Yes.
Continue.
So why is it important that we have to detect early oral cancers early? So basically, the main reason is if it is caught early, then the prognosis is better. So for stage 1 disease, the overall survival is around 80 to 90%. And for stage 2 disease, the overall survival is around 65 to 80%. So lesions in the early oral cancers can present as visible, palpable, and painless lesions. And for this reason, it can often be taken for granted and diagnosis can be delayed. Self-examination is something that can easily be done by patients without the requirement of any surgery. Coming to risk factors for oral cancers, we all know that tobacco alcohol plays an important risk factor. Along with that, betel nut, areca nut, which is very much common in our northeast area, potentially malignant disorders, exposure of sun, etc. Some of the potentially malignant disorders are leukoplakias, erythroplakias, oral submucous fibrosis, oral lichen planus, and we should be aware of what are the high-risk features. So these include red or speculated lesions, there's induration, any non-homogeneous or verrucous surface, rapid increase in size, and again, some locations have high-risk sites such as the lateral border of the tongue, the ventral tongue. So out of all the orally potentially malignant disorders, the proliferative verrucous leukoplakia has a malignant transformation of around 40 to 70%. Patients come with complaints of symptoms of non-healing ulcers, burning, bleeding, indurated masses. Loose teeth is something which we usually see in advanced cases, trismus as well, but trismus can also be present in oral submucous fibrosis, and the neck node may or may not be present. When it comes to examination, good lighting is very important, and inspection and proper palpation of the lesion and the surrounding mucosa should be done because induration may be present beyond the visible ulcer. And it is also very important that we palpate the neck bilaterally. So after seeing these suspicious lesions, biopsy should be done, and a punch biopsy and an incisional biopsy are usually the preferred choices. Incisional biopsy from verrucous-like lesions and indurated lesions, but there is no role for brush biopsies. So after taking the history and an examination of the patient, in our institute, we do an upper UGI endoscopy for the patients, check for any synchronous malignancies. Coming to imaging. So why is imaging important? Basically, we want to know how deep and extensive is the lesion, whether there is involvement of any neurovascular bundle, or whether the bone is involved like mandible or maxilla. So for oral cancer lesions, most of the time CCT is the imaging or modality of choice. But for lesions involving the tongue and the floor of mouth, a contrast-enhanced MRI is preferred. So AJCC 9th edition has clearly identified which are T1 and T2 lesions. But the difference between the 8th and 9th edition is the addition of the concept of depth of invasion. So what exactly is depth of invasion? So as seen in the photo that I've kept here, the black dotted line shows the interpreted mucosal plane, whereas the red dotted line shows the deepest point of invasion. So the distance between the two is known as the depth of invasion. The depth of invasion can be overestimated in proliferative or exophytic lesions, but it can also be underestimated in invasive lesions. So again, going back to the 9th edition, if the depth of invasion is more than 10 millimeters deep, that automatically upstages the disease to an advanced T4 lesion. And the second important thing is depth of invasion of more than 10 millimeter is a significant predictor of occult nodal metastasis. Treatment principles. So surgery is commonly preferred for oral cavity cancers and radiation in a few selective subsites. Reconstruction should be planned at the time of resection, and adjuvant therapy depends on the final histopathological report. So for stage 0 carcinoma in situ, wide local excision with adequate margins can be done, and also laser can be done. The advantages being it has minimal damage to adjacent tissues, it reduces acute inflammatory reactions, and there is lesser post-operative pain. Whereas for stage 1, stage 2 lesions, it can be a surgery-centered plan where we should do a wide local excision with adequate margins. The neck should also be addressed. And again, depending upon the final histopathological report, that will guide us regarding adjuvant treatment. Radiation can be performed in selected anatomy. Now, the advantage of surgery over radiotherapy is it has a shorter duration of treatment. It provides accurate histopathological reports that again can guide us for the need for adjuvant. It avoids the acute and late toxicities of radiation. It is cost effective and it can be repeated. This is a paper by Ellis et al. And here they have shown that the 5-year overall survival for patients with early oral cancers who have undergone surgery was 71% as compared to those who have undertaken radiation, which was 36%. So now when do we prefer radiotherapy? For lesions, small lesions in the lip, we can do brachytherapy. So this is a photo of our patients here in BBCI, where the patient has a T2 lesion in the lip, and we have kept the patient for brachytherapy. And also, it can be preferred for superficial palatal lesions without bone erosion. Coming to the approaches for surgery. So for surgery, we can go with an intraoral approach for small lesions, where we can assess all 3 dimensions. And also, we can use a cheek flap approach for any posteriorly based lesions. Mandibulotomy may or may not be used. So now, what is a mandibulectomy? It is the resection of a part of thickness of the mandible or a segment of the mandible. So usually, mainly they are of 2 types: marginal mandibulectomy, segmental mandibulectomy. And for early T1, T2 lesions, we perform marginal mandibulectomy while we're taking bony margins. So indications are for tumors of the oral cavity abutting the mandible without invading it, and for very superficial lesions which cause minor cortical erosion of the mandible. This is a classification of marginal mandibulectomy, where they have classified it as horizontal, oblique, vertical, and reverse marginal. So when we do wide local excision of the lesions, we should make sure that the margins are adequate. The reason being the margins reduce the risk of local recurrence, the need for re-resection, the requirement for adjuvant radiotherapy, and poor overall survival. So these are 2 studies, one done by the TMH group, which have adequately shown that a margin of 5 millimeter is adequate for excision of the lesion. Coming to reconstruction and rehabilitation. Before treatment, we should ensure that the patient is has adequate nutrition, weight is optimized, to get a speech and swallow baseline assessment. And if the patient has addiction habits like smoking, alcohol, we can ask the patient to go for psychosocial support and counseling. Whereas our reconstructive goal is to maintain tongue mobility and oral incompetence. When it comes to resection of the tongue, prosectomy is the surgery of choice, but we know that this can affect speech and swallow. This is a classification by Manelli et al. Is classified the tongue as anterior, middle, and posterior thirds, and accordingly, these are the defects from stage 1 to 5. So for type 1 resection, primary closure or secondary intention is the reconstruction of choice, whereas for type 2, we can go for a local flap or small free flap. This is another classification for cursing. Now, when it comes to reconstruction for tongue defects, we can opt for primary closure or flap or healing by secondary intention. So these are photos where I mentioned patients who have undergone primary closure, ones who have undertaken a flap reconstruction, and the last one by secondary intention. So this was another paper again by TMH group, which has clearly shown that healing by secondary intention has better tongue mobility and better articulation as compared to primary closure for reconstruction of tongue defects. Coming to reconstruction of gingivo-buccal complexes, again, we can go for primary closure versus loco-regional flaps versus free flaps. So the first photo is shown where we've closed using the buccal parafan, and we can see that there is a very nice mucosization. The second photo shows reconstruction using a submental flap, and the third one shows reconstruction by a nasally. So now for early T1, T2 lesions, it is important that we address the neck. The reason being that the chances of occult nodal metastasis is 30%. Now, if a node is positive, then it further decreases the survival by 50%. And in that positive node, if we find that there is extra capsular spread, there is a further 50% reduction. Again, this was a paper done by Anil Dikru, where he has identified that elective neck dissection improves overall survival by 12.5% and reduces the risk of death by 36%. So now for early oral cancers, we are performing elective neck dissection. Then comes the concept of sentinel lymph node biopsy. So now what is a sentinel lymph node? So as seen in the photos seen here, sentinel lymph node is the first echelon node which drains the primary tumor. So sentinel lymph node biopsy is a minimally invasive staging procedure used to identify and remove the first echelon node. So now why has this come into play? So we know that occult nodal metastasis is 30% in early T1, T2 lesions. And for such patients, we take them off for elective neck dissection. But now, 70% of the patients may not have occult metastasis. And for these patients, we may be unnecessarily doing neck dissections, which may result in overtreatment and can cause greater morbidity in the patient, such as shoulder dysfunctions, leak, etc. So for this reason, the concept of sentinel lymph node biopsy was developed, where the first echelon node is identified and excised and sent for frozen biopsy. Now, depending upon the report, if the report is positive, the surgery proceeds to a neck dissection. But if it is negative, then the patient is kept for observation. So after we've resected the specimen and sent for histopathological report, now that will dictate whether the patient receives adjuvant treatment or not. So depending upon the histopathological report, we can see some of the low risk, intermediate risk, and high risk features. And if a node is positive for T1, T2 lesions, the patient has to undergo adjuvant RT. The margins are positive, the patient has to get adjuvant CTRT. So these are some of the protocols and regimens for definitive CTRT, post-operative RT, palliative RT. Complications as surgeons that we anticipate during surgeries are bleeding, infections, bone breakdown. Especially for us, we are worried about if there's any flap compromise. Complications relating to neck dissections such as shoulder dysfunctions, leak, etc. And any radiation-related risks like leukocytes, pain, trismus, fibrosis, and osteoradionecrosis. And lastly, follow-up and surveillance is an important aspect where the patient has to get regular head and neck examinations with oral inspection and neck palpation. So initially, the frequency of visits for follow-up is initially quite high, but then gradually it spaces out over the years. For patients who have received radiation, the thyroid function should be monitored. And most importantly, we should educate the patient to return early if there's any new ulcer, neck lump, or any suspicious nagging lesions. And with that, I come to the end of my presentation.
Thank you, Dr. Arden. May I request Dr. Nagarkar sir to give your expert opinions?
Thank you very much, madam. And first of all, I'd like to thank Dr. Somai Chakravarti, my friend, for giving me this opportunity to interact with all of you. And nice to see the very famous Dr. Kudush Ahmed here, along with Dr. Rajuti Dash. And thank you very much, Dr. Ardent. It was a wonderful and crisp presentation
Thank you,
from
sir.
your side. And
Arden, close your PPT.
yeah, you can close your PPT. Yeah, so thank you for Madam also to conducting this wonderful session here. So Dr. Ardent, you have spoken very clearly, I think in a very crisp manner. You explained the importance of the depth of invasion. Certainly that is very, very relevant. I remember Dr. Shomai, whenever we would discuss with Dr. Jatin Shah, he would always say that a tumor might look superficial, size is same about 1 to 2 centimeters, but what about the thickness of the tumor when you palpate, especially the tongue?
Sir.
And he said that we have had multiple meetings with the American Joint Committee on Cancer and UICC, and I'm happy that the latest edition has incorporated it. And depending upon whether it's more than 10 mm, it straightway goes to stage 4. So it goes to show the importance. It definitely affects the prognosis. The chances of lymph node metastasis are higher. So I think that's one point which has been very, very clearly highlighted. That's one. Number two, for early tumors, sometimes you might have to just go ahead directly with an excisional biopsy. So that time itself, the confusion is whether to take a small amount or a bigger amount of tumor, then you'll have to go back again. So I think that's one decision you need to take, because most of the times clinically you will be able to have some idea. The issue is when there is some confusion between a pre-malignant lesion and a squamous cell carcinoma, especially of the tongue or of the buccal mucosa. There, of course, we should be, if you are planning an excisional biopsy, then let it be complete. Otherwise, go for, like you have mentioned, a punch biopsy, but take adequate tissue so that your diagnosis is established. And agreed that this is one of those tumors, head and neck cancer. It is unlike an abdominal malignancy or an intracranial tumor. It is seen, it is visible. It usually will show up with some pre-malignant conditions in the beginning. It could be leukoplegia, it can be submucous fibrosis, burning. So all those things are already there in these cases. So, and these patients have a history of, like Ardent has mentioned, a history of smoking, alcohol, or multiple things, multiple addictions, including, smokeless tobacco, so common in our country. So we are aware that this kind of condition is common, yet we pick it up late. But if we can pick up these conditions early and we are able to treat, the single message is most of these are preventable tumors, but suppose it has already happened, earlier the better. The earlier you diagnose these cases, the earlier you start the treatment, the morbidity and mortality is much, much lesser, and a patient almost becomes a normal patient, normal person. He can go back to his work. So I think that's the whole idea. Head and neck cancer is something which is very common in our country. It is the commonest tumor we see in males and quite common in females also. But definitely in males, it is the commonest tumor we encounter. And I think everybody should be aware how to handle these cases, how to refer these cases. And one thing I'll mention is whoever sees the patient first in whichever center, please use the TNM classification, so that such a simple classification to apply, so that with that he can then go forward and to the next to your own center, or he may be referred to another center. That's all, sir. Anything else we can discuss? Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Kudus Ahmed, sir, can you give your opinion?
Dr. Arden Dakhar has given us a very good succinct presentation. I'd just like to ask you about one thing. While planning for the treatment, what is the take on the the multidisciplinary tumor board? You have not mentioned, or I might have missed it. Can you give us a word on that? Because it is mostly in the cancer centers that the tumor boards are quite common, but in other centers, like in say medical colleges, I don't know how many have adopted the multiple disciplinary tumor boards. So what do you say about this tumor boards?
Dr. Arden?
So I had mentioned it in the slide, but I had not spoken about it.
Okay.
So MDTs is something which is quite important for us, especially regarding management for diseases where we have to decide whether the patient will undergo an upfront surgery or may need something like an NACT followed by reassessment, depending on different pathologies, different stages, different staging.
And another point was, when you take a biopsy, it is often seen that, the pathologist gives you a diagnosis of possibility of malignancy cannot be ruled out. Advise deeper biopsy. So do you make it a point to take a deep biopsy, adequately deep biopsy? Because this is something which, happens quite often and it still does occur. So what is the practice at Bibora now?
For such patients, so we try to repeat a deeper, whether it's a punch or a single biopsy.
Right.
Apart from that,
especially the verrucous types. The verrucous types are notorious for giving us a report of, repeated. Yeah, Rajyoti might have something to add to this.
Correct, sir. Verrucous type of growths are very superficially, those are with necrotic tissue and all. So most of the time,
camera on.
Most of the time we get that negative biopsy. So we always urge our resident to go for deeper biopsy. We go on taking the biopsy in the same point, so that after superficial tissue we get the deeper tissue. So the chances of positivity goes increased. So, and other thing I want to highlight is that the concept of cytology, brass biopsy and imprint cytology, those should not be practiced in regularly nowadays, because the accuracy of diagnosis of imprint cytology and brass biopsy are very less as compared to punch biopsy, because they gives us only the superficial tissue. So this should not be practiced in day-to-day practice, this brass biopsy and print cytology.
I agree, it's very true. And I think when we mentioned about, taking these repeated biopsies, it is actually the best principle is to have a good team. Most of the times, I think we have, like sir was mentioned, Dr. Kudusha has rightly mentioned about having a proper tumor board where the pathologist, radiologist, and other support plastic surgery, all the teams are there with you, maxillofacial. So I think here, when you have a good histopathologist and cytologist, so I think that makes our job easier. We can always have them with us during the discussion that this is how the lesion is. This lesion looks like a malignancy. This is a very exophatic lesion, looks like a verrucous, and we have already taken enough tissue. So that saves the time for the patient if we can get a report at the earliest, so that the further management is possible. And definitely, brush biopsy is not recommended because we can't treat it as definitive. It's not something which is routinely to be practiced. I think we should go for the routine, whatever has been the standard of practice. Yeah.
So rightly said, we are going through all our cases go through the MDT, multidisciplinary board. So regarding the surgery, we mostly take the decision this patient will go for surgery or not. There was one case which is sold for early case of lip, where brachytherapy was given.
For the lip,
yeah. So in those cases, we always take the opinion of the radiotherapists also, because we like to save the function of the lip. So brachytherapy has got a very good role in those type of superficial cases. So all our cases goes to the multidisciplinary teams, tumor board discussion.
Yeah, true.
And Arden, thank you for a very nice and elaborative presentation. Just I wanted to know one thing from you. Do you do imaging in all early cases, or you sometimes skip also?
Pardon, sir?
Do Do you do imaging in all cases in early CA, early cancers? Do you need it? Does it change your management, or sometimes you can skip also imaging?
Imaging is needed.
So suppose there is a growth in the angle of the mouth, small growth around 1 to 2 centimeter.
Imaging can be skipped in such cases.
Yeah, how does imaging helps you? This is a very
Basically,
clinical practicing. That's
yes,
why
sir.
I'm asking.
Yeah, similarly, small lesion in the buccal mucosa, which is very
Yeah.
obvious, it is anterior or in the angle of the lip. Yeah. So it depends because there's a lot of pressure on these investigations, usually in larger hospitals. Yeah.
So we have got a tendency of going for this imaging and in all cases, no? But these are some of the lesions which are located in the very angle of the mouth, very superficial growth in the lid. In some of the cases, our management doesn't changes even if we do a CT scan or imaging, whatever it is. Our management remains the same, but burdens on the patient get reduced by skipping of the imaging. So some of the things, some of the lesions which are very superficial, still we can skip our imaging process, imaging procedures. And one more thing I want to ask you, Ardent, where will you go for imaging in early cancers? Hello?
Yes, sir. So
In
when it's
early,
yes, sir.
there is a T1, T2 lesion in the oral
Yes,
cavity,
sir.
which are the sites you will go for imaging?
So when subsides is involving the lower gingival buccal surface area, where close to bone, abutting the bone, we want to know if there's any cortical superficial erosion or such lesions. We ask the patients to get a computed tomography CT scans.
Okay, well, some of the lesions which are very superficial to the bone. Suppose in the mucosa and the bone doesn't have got much tissue. Suppose a lesion, small lesion in the RMT retromolar trigone area. It's just lying just over the bone, no? So chances of bone involvement is more. So in early cases also you should go for imaging. Then in areas like your floor of the mouth, chances of lymph node metastasis is more. So in early cancers of floor of the mouth also you should go for imaging. And thirdly, the palate, where mucosa is completely adherent to the bone, chances of bone erosion is more. So in early cancers also you should go for imaging. But in other sites like buccal mucosa and all, where there is no bone and not near the bone, small lesions, you can skip the imaging. But these are the lesions in the RMT, palate, and the floor of the mouth. You should go for imaging in early cases also. Okay.
Yes, sir. Thanks.
Dr. Raj,
Before,
can you?
yeah,
Yes,
can I just put in a word? You see, whenever, we are lucky at this age that we have a lot of technology at our command, and we can make use of it. But during our postgraduate days in the 70s, you see, the CT scan was almost non-existent. The first CT scan, or what was known as the CAT scan in those days, in India came to AIMS in New Delhi. That was in the later 70s. And we all thought that, oh, CAT scan is not for ENT, It's only for neurosurgery and thoracic surgery and such disciplines, not for ENT. But then as, developments occurred, it was, during the 80s or late 80s or early 90s only that CT scan actually started becoming slightly more available throughout the country. Earlier than that, we never saw what an image of a head and neck cancer, picture would be like on imaging. The MRI came a little later, even though it was discovered earlier than CT. The MRI came into clinical use after the introduction of CT. So I think we should keep that in mind. Of course, we should use technology, but we should also keep in mind the early pioneers who actually had to do without much of imaging. The only thing was they had plain X-rays at their command, and at best an angiogram. So before CT and MRI came in, So these were the only things. Ultrasound also came in quite late. So it's well worth remembering these things.
Yes, definitely it is.
Dr. Arden, would
Yes,
Dr.
sir.
Arden,
Yes, sir.
just one year. Would you like to include NBI in any suspected cases? Narrowband imaging.
The
Are you doing
early suspicion lesions.
any sorts of suspected cases? Suppose I tell you there is no obvious growth, right? No obvious
Yes, sir.
growth, but you are suspecting. Many of the times we used to find in our institute also, it suspects, right? But there is no obvious mass. And on percussion, you will find that some sorts of query in duration, that things, right? It comes like this way, right? So would you like to go for NBI and how NBI helps in that?
NBI, basically we can see the vascular pattern, the capillary loops going into the facial lesion. And depending upon that, there's a can classify it as
Yeah, as Professor Nagarkar sir has told, the biopsy is the very important thing, right? So we have seen in some cases NBI also helps in that way, where from you have to take the biopsy, right? Because we are doing in that in our institute, whenever we have any suspicious that these are the areas, so straightaway is to take the patient to the NBI room, and under NBI guidance, as we used to take multiple biopsies from those areas. Because that accumulation of the hints, I don't know whether any other members also can agree. Professor Shivaraman, Professor Bhavna, what is your opinion in that way?
Thank you, sir. Good evening, everyone. This is Dr. Kranti Bhavna. Sir, NBI, so this is something which we bought a few years back. Obviously, for laryngeal lesions, there is no question. It helps you a lot. Even
Yes,
for buccal malignancies, and what
yes,
you very correctly told
yes, yes,
was not only that it gives you the representative area, but at
yes.
times also gives you the extent.
Extent, yeah,
So
excellent.
that way it becomes important.
Yeah,
If you have the facility, it is
yes,
good to use it.
yes,
And
yes,
the classification, now there are many modifications also.
yeah,
So it is very it's a good tool actually, and if the
yeah,
tool is there with you, one should use it. And
yes,
one very important thing which you again mentioned was at times you have endophytic lesions. You
yes,
don't have big cauliflower like exophytic lesions.
yes.
So in those cases also you can have these vascularity changes.
That's what it
And
changes.
sometimes you are confused with you can have multiple sites of suspicious looking lesions, and then NBI can help you, which is more towards malignancy. So if you have this tool, it is worth using.
Any time postoperative patient, have you gone for a
Yes.
repeat NBI? Would you like to
Uh,
prefer that one?
Sir, actually, post-operatively, frankly speaking, I haven't used much in my cases, but you can for suspicious when they come for follow-up. So yes,
Yes,
in one of the RMT cases,
yes, yes,
we
yes,
did see that.
yes,
And then obviously, then you go for PET and other things
yes,
when you are highly suspicious. So
yes.
that's what we do as a protocol.
Excellent.
Shimoda, can I make a point?
Sir,
I agree with Dr. Kranti and Dr. Surmai that yes, definitely it helps us to choose this best site for wherever you want to take a biopsy.
sir,
Definitely narrowband imaging has a role. Started off with our gastroenterologist, moved on to our laryngology, but definitely has a role to play for any mucosal
sir,
pathology. It could be the oral cavity also.
sir,
Yeah.
sir,
Sumaila, can I make a point?
sir, bolo.
So we are not that lucky to get early disease. No, we are working in a cancer institute.
Yes, 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 yes. I agree. I fully agree with you. I agree with you because the cases that comes to BBCI already these are on stage 3, stage 4, right? I
But the
agree with you.
India in the oncology center has got very limited role as of our experience goes. But
Yeah,
in a setup or in a medical college where there is a suspicious lesion and early lesions,
yeah, exactly, exactly. I agree. I fully agree. Yes, I
and one
fully.
thing in oncological setting, I like to say that NBI, they are having a lot of literature also. once you're resecting a margin, and if there is a field cancerization along with erythroleukoplakia, NBI sometimes help in taking the margins of the tumor.
Yes.
Clinically,
Yeah. Yes.
clinically
Yes.
not do
Agree with.
anything, but see with NBI, there may be some changes which you can include in your primary specimen, thereby getting less chance of positive margin postoperatively. So these are the role of NBI from my point of view.
And one thing which I think one thing could have included was the protocol of, as a cancer surgeons, we all know that role of PET, that is something which we could have mentioned in this talk. It would have added just a thought about it. That's it.
Actually, madam, the topic was early cancer, so what we
Oh,
can
yeah,
do.
sorry. Okay, fine. Yeah, got it. Sorry.
So it gives that much importance to PET scan and all.
Yeah, got it.
Not to slides, I suppose.
Okay. Hello everyone.
Hello.
Yes.
Yes.
Yeah,
Hello.
Dr. So it's maybe a little bit chilly with all those head and neck oncologists. So in a situation like if a very small tumor, 1 centimeter tumor, and it's in the angle of the mouth, and with biopsy it came out to be a negative. So though we are suspecting that it may be a early cancer or a dysplasia or whatever it be, but when we go for the surgery, so what should be the margin in those cases?
Arden, please reply. Then we'll come in. Dr. Arden,
Yes, sir.
please give the answer.
So, so
You're sleeping. Okay, Anjan,
sir, the margins. Yes, sir. Yes.
okay, you want to say something? Continue. Carry on.
The margins, as mentioned previously, sir. Usually for excisions, we take a 1 centimeter margin for all oral cancer lesions.
If it comes
For
out to be a
suspicious lesions, we
negative
can go
in
for a
biopsy,
frozen
then
biopsy as well, sir. A frozen section.
yeah, present section is right, but we don't have present section in all setup. So in those cases, how it should proceed? We do
Anjan,
a
some
biopsy and come for the repair and for the second surgery, or how should I proceed? If
no,
mostly in the critical area like the angle of the mandible, angle of the mouth, if we take the margins to is a 2 centimeter margin or so, so it may be some disfigurement. And if it comes up to be negative for cancer, so it may be a little bit of disfigurement also.
no, some of the points you need to consider, Anjan, whether patient is a
Yeah.
male or female patient, because male patient has got more propensity of malignancy. Secondly,
Right.
whether the patient has got history of tobacco chewing or not, any form of tobacco chewing. Then
Yeah.
whether the look, how is the look of that lesion, whether it's proliferative, erythroplakic type, with fungating type of things. Those are the things you need to consider. So clinically, it will give you some idea regarding whether the chances of malignancy or not. So if you have got a chances of malignancy in clinical look, you should always excise it as a malignancy only by taking at least more than 5 millimeter margin, or maybe from 7 to 1 centimeter margin, 7 millimeter to 1 centimeter margin.
Okay. Okay.
You should be having a concept of excising it to be considering it to be malignant only. Then accordingly, you'll have to take the margins also.
Right. Okay.
So
So
first
if
surgery,
the biopsy comes out to be negative also, we consider it as a clinically
yeah,
look
yeah.
like malignant, and we treat it as a malignant.
If it comes as negative, also you are safe on your side, no?
Okay.
I think
So
we should
once it
discuss with these patients well in advance, because definitely I think if it is explained to them that it looks much like a malignancy, and that's why, like Dr. Raj Jyotidas has rightly mentioned, that so many of these features will give us a hint that it looks like a malignancy. And I think in majority of the cases, it turns out to be also. Of course, there will be a small percentage where it could be, some sort of a pre-malignant lesion or something like that, which is masquerading or looking like a malignancy. But otherwise, I think most of the times we are able to make a diagnosis. And if we are able to explain to the patient that we are trying to do the best for you, we are removing it, so that considering that in mind, I think that should be okay. And if your hospital has frozen section, of course, nothing better than that then.
Yeah,
But
I
even
think I think Dr. Nagarkar has put a very good point there. We must always discuss with the patient, and the patient must agree with the plan that you are putting forward. Because later on, the patient or the party don't turn out to be aggressive. You have to save your skin also. So yeah, you have to sit with the patient, sit with the party, explain to them all the pros and cons before you take up for the surgery. And as
one more,
Rajuti said, you have to treat it as a malignancy. If you are going to have even an inkling of a suspicion that it might be malignancy.
and even it comes as in benign, after taking 1 centimeter margins also, patient will be happy looking into the biopsy report. But if it comes
Yes.
positive, taking a 5 millimeter margin, then we are at fault.
Yes, I think
That's
that is
exactly
very important
Dr.
to.
Anjan, there are some questions in the chat box. Can Dr. Anjan and Dr. Rajuti take the questions?
What is the question, madam?
There are some questions. Just a minute.
Where the chat box is not opening?
Yeah, you open the chat box. There's a Fukon sir has asked, what non-invasive procedure for diagnosis of oral lesion?
So
For
that we have,
tongue, why importance given for
so that one we
Yeah.
have already discussed. NBI is also non-invasive technique of diagnosing. It will give a chances of malignancy. We can suspect some lesions, and we can make them take a biopsy, or we can observe those high lesions also. And second, what is the second question?
for tongue, why more importance given for neck address?
Yeah, tongue is a mobile structure. Propensity of tongue having lymph node metastasis is as high. It's more than the buccal mucosa tumors and all. So neck management in a tongue case is very mandatory, and it gives a actual staging of the disease also. Because we have got only mobile structure in the oral cavity is tongue. So chances of spreading of malignancy to that neck is also more. So we should give more importance to the neck dissection, and it should be an adequate one.
Another question from Fukon sir only. Biopsy is not accepted by many. Which is the protocol? Imaging or any non-invasive procedure which helps from in counseling?
No, if you are suspecting a malignancy, biopsy is the investigation of soils, which will give us 100% diagnosis. It's not the imaging, not any other thing that will give us 100% diagnosis. Only the biopsy. We will have to convince the patient. If you are allopathic, if you are going to do allopathic treatment, that's how I convince the patient in my OPD. If you are going to do allopathic treatment, you have to go for a biopsy. Because
Raj,
I'm not.
this is a final court of appeal. Biopsy is the final court of appeal. There is no other alternative like biopsy. I think it is a final court of appeal.
Absolutely. There is nothing better. It's
Yes.
completely to have a biopsy
Yes.
for any definitive management. The
Yes.
other investigations are supportive to deciding
Supportive
the plan of
yes.
management. Certainly.
Dr. Kranti Bhavna madam has wrote, it is before NBI. NBI helps also in assessing the extent of the lesion and also site of biopsy.
There is
Dr.
one
Ori-
more question in the chat box, intraoral ultrasound.
Yeah, that is before that one, when to subject the patient for PET-CT in early cases.
Madam, let us discuss this point first. Intraoral ultrasound. Intraoral ultrasound was practiced earlier with a probe inside the mouth, but it's very cumbersome process. Nobody will like to put an ultrasound probe in the oral cavity.
Yes.
So rather than going for intraoral ultrasound, people used to go for MRI and all. So intraoral ultrasound is not in practically used nowadays. I've never seen doing somebody, but it's completely a book knowledge nowadays.
Rina Raha has asked for the when to subject a patient for PET-CT for early cases.
I think PET-CT has limited role in early T1, T2 cases
Yeah.
because of malignancy in the distant metastatic sites are very, very less than maybe 10% also. So the role of PET scan is very limited. No, we are not practicing for PET scan in the early T1, T2 lesions in the oral cavity. PET scan is mostly indicated for T3, T4 lesions, recurrent disease, and with a lot of nodal burdens, very aggressive histology, something like those.
It is when you are having a high index of suspicion of distant metastasis. That is where you talk about PET-CT. not in early cases.
Dr. Kranti Madam has written one also discussion about varicose dysplasia oblique CA.
I can just add one thing about varicose because many surgeons, we are in a, there are times when you take multiple biopsies. So we recently had a case with an extensive varicose lesion all around. And we know that recent literature says that varicose carcinoma has to be treated completely as almost as squamous cell. But when you have dysplasia and when you keep getting biopsies of dysplasia and extensive dysplasia, then these are radio resistant tumors, so it's there that sometimes you have to take a decision as to, because and if these are lesions which are covering almost a large part of the buccal, then you have to also reconstruct them. So what is the opinion of the panel on extensive varicose dysplasias where you have taken multiple biopsies? So I'll tell you what we did in our case, but I just wanted to understand from the panel as to how do you deal with such cases?
Madam, what we practice in our institute is that most of these are varicose type of growth, overlying the alveolus, then buccal mucosa, extensive growth. And if you go for excision of those, they might require very sophisticated reconstruction also. So we need to counsel the patient regarding everything. We have to excise it. There is no other medication other than surgery.
True.
So we have to go for surgery. We have to counsel the patient preoperatively. And what we do in during surgery is that we are lucky to have a frozen section. So some of the suspicious area from the excise specimen, we go for frozen section. And if we go for, if we get any malignancy or suspicion of malignancy, we treat accordingly. And reconstruction has to be done according to the defect we create.
Yeah.
And counseling and talking to the patient preoperatively is a very important thing. You have to counsel the patient, and adequately excision and reconstruction had to be done as per requirement.
Yeah,
That's
so
how
that's, yeah, true. So I think we can summarize that even for dysplasias which are extensive and multiple biopsies are still not showing varicose carcinoma, in such cases also you need to, that's what we did, and we did an complete excision, and the frozen, we did send our frozen, which was again negative, but since that was a big lesion, we had to excise it, we did our free flaps, and then, the patient is in follow-up. So just to a take-home message for dysplasia cases also, when there is, extensive dysplastic lesion, but the lesion is big, you need to really counsel the patient and make them understand that this can, number one, be converted to carcinoma. And number two, obviously, that it has to be taken out. You cannot leave it. And obviously, male patient with history of addictions and all that becomes important in decision making.
Yeah, I think
some small percentage of this
Yes, sir.
this may turn into complete dysplasia and may go into carcinoma in situ, then into invasive carcinoma. So you
and
take it.
carcinoma in situ is to be treated as full-blown carcinoma now. So
I think many of these cases come to us even bilateral, and the varicose carcinoma is usually some sort of a very highly, differentiated squamous cell carcinoma.
Yes.
Or it can be invasive. It can be just a varicose carcinoma, very superficial. You can have, pockets of invasive carcinoma along with it, or like you rightly mentioned about only getting dysplastic, tissue. But I think the management should almost remain the same. And some of these are very extensive tumors, but I think one thing good about these tumors is the overall prognosis of these.
Prognosis is very good, yeah.
So if we can, of course, it looks bulky, but they come out, quite well. I've used apart from even the routine conventional surgical management, including laser also I've used.
Laser also, yeah. We have also used laser.
Yeah, you must have. And they do exceptionally well. And I think even if it's a bulky tumor, patients are pretty satisfied. And usually there's no lymph node involvement. Even if it's a bulky tumor, it's a superficial tumor. I think we better treat it as a malignancy, and that gives us better results. Yeah.
Yes, sir. Thank you.
Thank you. Thank you all. It was a very nice discussion. So I think we can close this. Last is vote of thanks. So respected Professor Nitin M. Nagarkar sir, our speaker Dr. Arden Deidakar, esteemed moderators Kurdus Ahmed sir, Rajyoti Das, respected teachers, dear colleagues, and postgraduate students. On behalf of the Scientific Committee of NEBAOI, it is my privilege to propose the vote of thanks today. Enriching classroom session, early oral cancer, workup, and management. We express our sincere gratitude to our distinguished expert, Professor Nitin M. Nagarkar, sir, for sharing his vast experience, valuable insights, and practical guidance on this important topic. For expert comments and academic wisdom have greatly enhanced our understanding. Thanks to Dr. Kranti Bhavna Madam for her expert opinion on importance of NBI and verrucous dysplasia on early oral cancer. Thanks Dr. Shubhama and Dr. Anjan for their inputs. We are equally thankful for our speaker, Dr. Arden Kedakar, for delivering an excellent presentation and providing a comprehensive overview of the evaluation and management of early oral cancer. Our heartfelt thanks also goes to our moderator, Dr. Kudus Ahmed sir, Dr. Rajyoti Das, for active participation on discussion and skillfully conducting the session and facilitating and engaging academic sessions so fruitfully. Thank you, sir. We sincerely appreciate all NEBAOI members and postgraduate students who joined the classroom and contributed their activity participation and thoughtful interaction. Thank you all once again and making this evening a great success. Thank you all. Good night.
Thank you all.
Thank
Good
you.
night, sir.
Thank you.
Thank you very
Thank
much,
you.
sir.